Well, I'll take the time while the slides are going up to thank Dimitri for inviting me and for the entire EIP coordinating committee for having such a wonderful meeting. It's great. It's my first visit to Turkey. Okay, so again, I appreciate the opportunity to come and debate what I think is an important clinical and policy implication for people in the developed world and probably increasing in the developing world. Now, Doug and I are both from the United States. In the United States, we often think if a little bit is good, a lot is better. And we usually think a lot is better, especially when we have it most convenient to us. However, my job today is to say a lot of cholesterol screening is not better. In fact, to give you the con position, why universal screening is not justified. And my disclosure is I was a member of the NHLBI expert panel that Doug mentioned, but I don't agree with every recommendation that the panel came out with. So today, I'm going to reiterate some history of U.S. guidelines, go over the rationale for screening, mostly as a straw man, tell you what the expert panel did not consider, tell you what we can do to evaluate pediatric screening, then revisit the screening rationale, and I think in my rebuttal period, talk about what pediatric providers should do now. So Doug didn't mention this specifically, but the recommendation to screen after 2 years for family history of premature cardiovascular disease or hypercholesterolemia actually goes back almost 20 years to the 1992 recommendations of the National Cholesterol Education Program published in Pediatrics. Now, he mentioned the U.S. Preventive Services Task Force 2007. He said it was an exhaustive systematic review, but what he didn't mention is that their conclusion was there's insufficient evidence to recommend screening. In 2008, we saw the AAP Committee on Nutrition recommendation that he told about, which basically reiterated the 1992 recommendations and gave us some more guidelines about drug treatment. And again, just a couple weeks ago, the NHLBI expert panel recommending universal screening at 9 to 11 years and later adolescence. So we all agree, and Doug said this, there's lack of evidence on long-term impact, comparative effectiveness, and cost-effectiveness of childhood lipid screening. But the question is, does that matter? So what's the rationale for cardiovascular risk factor screening in children? And Doug mentioned a few of these things. One is atherosclerosis starts in childhood. And yes, we've known this since this landmark publication in Korean war victims. Cardiovascular risk factors, including lipids, non-HDL cholesterol, is associated with the extent of atherosclerosis in adolescence. Risk factors, including cholesterol, track from childhood to adulthood, and Doug mentioned this as well. The obesity epidemic has led to more dyslipidemia in children. Family history-directed screening misses many children with high cholesterol levels, which Doug spent most of his time talking about. Randomized controlled trials of statin treatment in adolescents with familial hypercholesterolemia and related conditions, which occur in about 1 in 500, show stabilization of atherosclerosis and little evidence of harm. So with all of this, does it matter that we don't have this lack of evidence on long-term impact? Well, it all depends on how you look at it and what you look at. So here the PR department is turning the chart upside down, and for me, the question goes back to the principles of screening. So I try to start this from first principles. And if we talk about a screening test, one of the first things we want to know is the validity of the test. So here we're talking about a test in childhood, LDL cholesterol. It can either be high. Let's see, I think I'll try this pointer. It can either be high or it can be low, depending on, and that depends on where we put the cut point. And the outcome, premature cardiovascular disease in adulthood, is what we're trying to prevent. That can either occur or not occur. So then you can have 4 possible combinations. You can be right 2 ways and you can be wrong 2 ways. So those people who have a high LDL and go on to get the outcome, those are our true positives. Those are the ones that might benefit from early intervention. Those who have a high test result and don't go on to have early cardiovascular disease, those are our false positives. Then we have our false negatives and our true negatives. And here you can think about the false negatives and true negatives as people who undergo screen and have a low LDL, or people who never get screened, like the people who would be not screened under a family history directed type of screening program. So the 4 possible outcomes of the screening test: the true positives get potential benefit. Let's start with the true negatives and false negatives. The true negatives have a little bit of risk and harm just by undergoing the screening test and undergo a little bit of cost. The false negatives undergo the screening test, and they may have harm later because of the morbidity we didn't catch. The true positives are the ones that could benefit. They and the false positives have a lot of risk, potential risk and cost, because the risks and costs are from the initial blood draw, further workups, labeling, etc. And they're also from the interventions among those who screen positive, and that applies to both the true and the false positives. So what did the expert panel focus on? The expert panel focused almost exclusively on the potential benefit of true positives and the potential harm of missing cases. Very little on the risk or harm of the true positives, not at all on the cost. We don't care so much about the true negatives, so what didn't they focus on? The false positives. These are the people that have a high cholesterol level in childhood, but will never go on to get premature coronary disease as adults. So why is it important to focus on the false positives? Well, here's one reason. I think I'm getting a positive response here. You're getting a false positive. But more to the point here, false positives, again, they accrue risk and cost, but no benefit. Tracking and prediction that Doug mentioned. Tracking exists. People who are high in cholesterol tend to stay that way over time, but not perfectly. That's tracking of cholesterol in childhood to tracking of cholesterol in adulthood. Tracking of cholesterol in childhood to events will be even worse. So there'll be lots of false positives. Now, I want to give you an example from childhood blood pressure, because no one has worked through this completely yet in terms of lipids. But my colleagues and I did this with blood pressure about 20 years ago. And what we did was we asked the question, so what if we take blood pressure at age 10 and we want to predict hypertension 10 years later at age 20? And we did this in a cohort study in which we measured blood pressure very well at age 10, very well at age 20. We did some statistical adjustments to do away with in-person variability in our tracking correlations. We were trying to maximize the positive predictive value. That is, somebody who tests positive in childhood would have hypertension in adulthood. And here we're going to look at males and systolic blood pressure, because that increases our probability even more. Females don't have as much hypertension, and diastolic is more variable. So this gives our most ideal situation of prediction. Okay, now suppose we look at a boy who has the 95th percentile of blood pressure at age 10. That's 117 millimeters of mercury. So that's our cut point for stage 1 hypertension. We compare it with a boy who's at the 50th percentile. The relative risk of developing hypertension at age 20 is 5. That's a big relative risk for epidemiology. But in screening, we're interested in absolute risk, not in relative risk. So if we take that same 95th percentile, we look at the specificity. That's the number of kids who go on not to have hypertension who are correctly classified as in childhood. That's 0.97, excellent. The sensitivity is those who will go on to get hypertension who were correctly classified in childhood. That's lower, that's 17%. If you run through the numbers, in this population, the positive predictive value, the probability of having hypertension given a high blood pressure in childhood, is 44%. Therefore, 56% of all the positives are false positives. And we know that the positive predictive value will be even lower for clinical endpoints than there would be for predicting hypertension. And just as an aside, suppose we take these same numbers and instead of a sensitivity of 17%, we want to achieve a sensitivity of 80%, which would be good for a screening test. The relative risk would have to be about 3,000. So this tells you the difference between epidemiology when we're doing with etiology and epidemiology when we apply it to a clinical situation. More tribulations. Behavior change interventions, which is most of what we're going to do, not drug interventions, are difficult. We can change behavior in the short term, but not in the long term, and they tend to be costly. Well, would population approaches do any better? Well, let's back up a minute and say what we mean about screening versus population approach. Screening, or high-risk approach, is a strategy to identify affected individuals and then modify the risk factors in them. In contrast, in a population approach, we try to modify risk factors in everybody. And we can do that through an active approach, where we try to change behavior on the individual level, or a passive approach, where we take policy or environmental levers. Well, this is really important in cardiovascular risk, because even though individual risk is higher with higher cholesterol levels or blood pressure levels, most cardiovascular disease occurs in people with average levels. So on this slide, in the blue, you see the distribution of cholesterol levels in the population. The red line is the individual risk. As you go up in cholesterol, your individual risk is higher. But look at the percentage of cardiovascular disease that occurs in the people with normal cholesterols. So between 5 and 5.5 millimoles per liter, you get 17% of all cardiovascular disease. That's the same as everybody above 7. That's because there's so many more people here. So even though they're at lower risk, you have a much bigger burden at the normal levels than you do at the higher levels. And if you combine that with the fact that the risk factor distributions among those who will and will not develop disease are not that distinct, as you can see here, wouldn't it make more sense just to try to take this curve and move it to the left a few milligrams per deciliter than it would be to go through all that screening and identify people over 7 and have to worry about all the things that we talked about, the false positives and people who are not going to respond and all the cost? Well, Nancy Cook did a beautiful demonstration of this. She published this 15 years ago, suggesting that a 2 millimeter reduction in diastolic blood pressure on everybody would result in a 17% decrease in hypertension, 15% reduction in stroke, 6% reduction in risk of coronary disease. And this reduction in coronary disease is more than successful medical treatment of all those with hypertension. So the potential power of a population approach. All right, so I've mentioned all these things. Now, how could we possibly put this all together? Well, there's not ever going to be a long-term randomized controlled trial of lipid or blood pressure screening in childhood that follows the kids for 50 years until we can measure their coronary disease outcomes. And even if there were, maybe the test would be obsolete by that time. So what we have to do to figure this out is combine benefit and risk and cost from shorter-term studies in childhood and early adulthood with the well-known epidemiology in adulthood that Doug so nicely presented. And one way to do this is through a decision analytic framework. So our clinical decision is screen or not screen, right? So on the top half of this decision tree, let's say we decide to screen. Well, we've already gone over the 4 possible outcomes of screening. Let's say we decide not to screen. Well, not screening doesn't mean no intervention because, again, we have the possibility of doing population-wide approaches. So we undertook this in relation to blood pressure, and we asked the question, how effective and cost-effective is childhood blood pressure screening in reducing lifetime coronary heart disease risk? We looked at universal screening and selective screening. We compared it with no screening intervention, and we also looked at population approaches for a hypothetical cohort of all US 15-year-olds. And this was the model structure. First, we took advantage of a coronary disease policy model that's been in existence for 20 years, a very well-known, sophisticated model that tells us if you enter this model at age 35 with certain risk factor distributions and you're cared for in the way that people are cared for clinically in the US, then you can estimate what the risk and the cost of coronary disease and other cardiovascular disease is. Then we put that together with data that we were developing on blood pressure distribution, tracking, screening, and treatment from age 15 to 35. So linking these two, and then doing it on this baseline cohort of all 15-year-olds in the US. Okay, so this is a little complicated, but this is the basic structure of the model. Our overall approach was to compare no screening, which also means no intervention, and no effect on blood pressure, with screen and treat and population-wide approaches. So in screening, we had several universal screening approaches and several selective screening approaches. For population, we had active and passive approaches. And then we said, well, they can get different kinds of interventions, weight loss, exercise, salt reduction, treatment for secondary causes, policies to increase physical education, or a salt reduction campaign. And to skip to the punchline, here it is. We couldn't even compare the population approaches with the screening approaches, because whenever we did that, the population approaches were better. All screening strategies were more costly and less effective than the population-wide approaches. And here you can see the best one was a salt reduction campaign, increased PE classes, and then individual interventions. So these are your passive and these are your active population-wide approaches. So the population strategies to reduce blood pressure appear very effective and definitely more cost-effective than any screening strategy. No one's done this for lipids yet, but the principle should be the same, and the initial risks and costs, because it involved blood draws, is higher with lipids than it is with blood pressure. So in medicine, we can only do bits and pieces. So the bigger picture, you need to see the public health guys. All right, let's return to our rationale for screening. Atherosclerosis starts in childhood. Yes, we want to prevent it, but population approaches may be more effective and less costly than screening. Cardiovascular risk factors are associated with the extent of atherosclerosis. Yes, but that's not a screening issue. That's preventing the risk factors from the beginning, a primordial prevention approach. CV risk factors track from child to adulthood. Yes, but tracking does not translate into high predictive values. Most positives will be false positives. The obesity epidemic has led to more dyslipidemia in children. Yes, but obesity is most associated with low HDL and high triglycerides, not LDL. And treatment goals, rightly, are based on LDL cholesterol. Family history-directed screening misses many children with high cholesterol levels. Yes, universal screening will certainly miss fewer cases, minimizing what you might call the false negatives, but will vastly increase the false positives, who have no benefit but cost and risk. Short-term randomized controlled trials of statin treatment show stabilization of atherosclerosis and no evidence of harm. But they're short-term. We don't know about long-term efficacy and especially safety. Here's a fun safety slide. Which button do I push? Usually we just punch them both. Detect cancer, cause cancer. We also don't know about safety in the real world. The day after the NHLBI expert panel guidelines came out, there was this perspective in the New England Journal. All statins are associated with adverse events, muscle-related, cognitive, memory, elevation of liver enzymes. They occur with a frequency of less than 5% in randomized controlled trials, but as many as 20% in clinical practice. And we want screening to be in real clinical practice, not just in the randomized controlled trial setting. Most of our treatments will be lifestyle behavior change, not drug treatments. We're not very good at this in the clinical setting. And there's no evidence actually that knowing your number actually helps adherence to guidelines. So in summary, this lack of evidence on long-term impact, comparative effectiveness, and cost effectiveness is very important. And I'd like to remind you of one other thing, and that is that our ethical standard for screening is higher than our ethical standard for diagnosis. In screening, by definition, we're doing tests on asymptomatic individuals. We're going to them and saying, we have a great test for you. They're not coming to us and saying, help me. Therefore, the harms fall mostly on the healthy. Therefore, first, do no harm. Universal screening is not justified. Thank you. All right, thank you very much, Doug. It's been fun to go against a formidable adversary. And you ended with actually an excellent question, which I'd like to come back to. I don't think there's a great answer. I do think, however, that there is a lot of there's a lot of opportunity for doing research. I mentioned the Cardiovascular Research Network and others. So I wanted to make just a few additional points, and while I'm doing this, to respond to some of the points that Doug made. So Doug talked about adults. So let's talk about screening in adults for a minute. Screening in adults is littered with costly failures, such as chest X-ray for lung cancer. We've thought, in the last 10 to 15 years that mammograms and prostate-specific antigen are great screening tests, but we're starting to back off those, at least in terms of certain age groups. In adults, lipid screening is still not settled, including what age to start. So the National Cholesterol Education Program says start at 20 years, but the U.S. Preventive Services Task Force says 35 in men and 45 in females. How could it be that we're going to do this extensive screening in children when we're not even supposed to screen from 20 to 35? Not only that, but how should we screen? Earlier this year, Nicholas Wald came out with this very intriguing paper suggesting that screening just with age, in fact, age 55, is as good a screening test in adults as using multiple risk factors. Yeah, my age is way too high. In the face of this uncertainty, is it really time to get more aggressive with childhood cardiovascular disease screening? And this is the algorithm that appears in the expert panel. You're not supposed to be able to read it because it's too complicated. How easy is it for people to follow this algorithm all the way through? The only study I know of that looked at something like this, it was about 20 years ago, and it suggested that of about 1,000 families that were participating in a program like this, only one went through the entire program. Do we have more useful things to do in our limited time with parents and children? This doctor is saying, I'm concerned about your cholesterol level, when clearly there are other things to be concerned about. And I want to come back to this. It all depends on how you look at it and what you look at. Because Doug is right that the NIH, the AAP, the AHA have all got behind this guideline. But if you get behind the dashboard a little bit and see what key questions were asked, you might have second thoughts. So the U.S. Preventive Services Task Force was actually in 2007, not in 1997. And you can see here that they asked a balanced range of questions: overall effectiveness, natural history, accurate screening test, adverse effects, treatment effectiveness, adverse effects of treatment. They didn't ask about cost or cost effectiveness. But now look at the questions of the expert panel, and especially the fact that there were no questions on accuracy of screening test, adverse effects of screening, adverse effects of treatment, or cost effectiveness. So how can we get the right answer if we ask the wrong questions? And so I want to go back to our U.S. Preventive Services Task Force, which came out in 2007 saying there's insufficient evidence for or against screening lipids in childhood. They asked the right questions. They did an extensive literature review, just like the expert panel, but the questions were different. And for some reason, people in our country are tending to throw out the window the findings of our task force, even though it does excellent work. So mammograms, and now kids and lipid screening. One question to think about is, are we actually over-medicalizing a public health problem? At last, a cure. I didn't even realize that it was a disease. What should primary care providers do in 2012? I don't know. Many are following family history-directed screening. I think it's okay to continue that, awaiting more data. One of my recommendations is that we really should limit intervention to those who have very high LDL cholesterol. In fact, maybe those who have LDLs high enough to warrant medication. I don't know if that's the right thing, but that's something that's a researchable question. And as Doug said, in the face of these new guidelines, it's very hard to justify to your colleagues no screening, even though that actually might be the right thing to do. Thank you.